Yeah, hi everybody. This is another supplemental recording on that chapter I was discussing, the self study chapter. So, where I left off was at toxins. Toxins are important because they're the principal way that bacteria. So, I'm looking at the PowerPoint, by the way, of Callan's chapter 11, as you can see up here, fundamentals, et cetera. So, you can see all that with my cursor, and you can just follow along with this. But they are toxin by definition is a poison. It's another way to say it. And so and we basically name them with regard to their target. So neurotoxins, tetanus, botulism would be neurotoxins. Interestingly, neurotoxins act very rapidly. Nerves conduct business rapidly, but interestingly, and you might remember when we talked about the nervous system and anatomy and physiology, the anatomy, there's conduits where neurotransmitters go to the tip of the nerve or the axonal tip to be released. Those conduits can bring toxins in the reverse direction back toward the brain, if you want to think of it that way. So they act very, very rapidly. For instance, certain poisons like a venomous snake, cobras, are neurotoxins. Copperheads, indigenous to this area, but again, they're found in and around this area, as are rattlesnakes, are neurotoxins. Rattlesnakes are, in contrast, are what are called hemotoxins. So you have a little more time. Doesn't mean that there's any great benefit. I mean, they're lethal, but if you have a little more time to get treatment and and to survive those kinds of things. So neurotoxins act very quickly. Enterotoxins are when you get food poisoning, it's an enterotoxin. This is a toxin that entero again is the gastrointestinal tract. Whenever you see that, you know exactly where it is. And so when we hear about that, most food poisonings are not lethal. The only one really is botulism. And if it's not treated properly, because then botulism effectively it is a type of food poisoning, but that particular toxin, even though it is by definition an enterotoxin and affects the gut, it also affects the nervous system. And here's hemotoxins affecting red blood cells and kidney toxins. So all of those worth noting about all of those things. So now this is what it sums itself very, very well with what we call hemolysis. This is what you're doing in lab. This is very weak, so it's very, very timely. We look at hemolysis, whether it's total beta hemolysis, whether it is partial, gobbling up and sort of breaking down some. It's almost the analysis I would give you would be like rust. As you can see, rust, when it begins to break things down, it begins to have different colors. Or you might think of it as a bruise, a black and blue mark that changes colors. That's kind of what that kind of alpha hemolysis is. And then you have basically what they call gamma hemolysis, where it doesn't hemolyze at all. It doesn't have any effect on it. So they're showing a pretty good example, and you would do this kind of a streak pattern in the lab, perhaps you have. The endotoxin is different. It's inherently part, and it's only in gram negatives. We've discussed this. Lots of significant problems because the nature of those kinds of toxins, your body, it's a giant systemic response. And so inevitably, these are the things that you can see: fever throughout, diarrhea, hemorrhage. What those toxins, your body mounts it, and effectively it's an immunological response that we see that depending on where it is released will be damaging tissue because of the profound amount of immunological response. In some ways, it has the characteristic of what we call a super antigen. So super antigen really activates about 20% of your helper T cells, which produce tons and tons of these chemicals called cytokines, which really do damage and will probably be mentioned as we move forward. So all of these, Salmonella, Shigella, Neisseria meningitidis, E. coli, because the strains that are dangerous, typically they carry this, it's called Shiga toxin. And it's the one where you hear about that killer strain of E. coli, the H7O157, that all have typically that came from a bacteriophage infection of the bacteria. And what it led to is this toxin. Okay, not all of these, they're certainly not equivalent. Meningitis, that's why it's so dangerous, bacterial meningitis, because of the toxins it produces. It's rapid, kill in 24 hours. I'll give you some personal insight into salmonella and talk about that kind of an infection. We really don't get to gut infection that much, but I'm sure I'll mention it in passing. But just for the sake of clarification here, salmonella food poisoning, which I got from raw fruits and vegetables, basically lettuce and tomato, from Panera's back in '06, 20 years ago this summer. Not Panera's fault. They had a similar outbreak at Sheetz, just wherever their produce suppliers from some of these local restaurants. They didn't know. And maybe they should have taken additional steps of making sure to be more thoroughly washing these things. But I'm not an admonishment because it's the food industry's, that's an ongoing problem. I ended up, had a sandwich on a Monday that the students got me when I was teaching a summer micro class up at BC3 up in Butler. And by Tuesday, I was in big trouble. By Friday, I was in intensive care. Bloody diarrhea, dehydrated. I've told you the anecdote. So sick, they called my 87-year-old mom and told her I was close. I was in St. Margaret's Hospital, really a seminal moment of my life for a lot of reasons. Really significant. I mean, that's really the closest I've ever been, and it ain't good. Because here I was. Remember, I was 55 years old. I wasn't very old when that happened. All right, moving on. And they're just showing you the effects that they can have in general. So try to be familiar with them. And yeah, so I think this will help you as you begin to understand these things that are there. And I mean, I don't get a lot. This is too small for me to read anyway. And I guess they're trying to look at various factors that are there, and if that helps you, go ahead and look. When we talk about infections, it's different. When we talk about a localized infection, I mean, you get a pustule, a pimple, like we've all had, or a teeny tiny cut, and all of a sudden it gets an infection, some dirt got into it, and oh my goodness, we call those localized infection, a little patch of athlete's foot, localized infection. It's confined to that area. The only problem is if it starts to spread or it becomes more severe, but at least it's localized to an area. It's what your body seeks to do. Systemic infection is just the opposite. It spreads, whether it spreads by the bloodstream, whether it spreads by the lymph, whether it travels by the nerves. You can see rabies or within the cerebrospinal fluid, like meningitis. This is not good. Okay, and typically this is where we see this happen. This rubella, this German measles, mumps. Again, it's paramyxovirus. Types of things. Syphilis, you'll see, goes all through your bloodstream. Chickenpox, all over the place. Measles would be in the same category. So even though you may demonstrate it more distinctly in a certain area, it's really going through your whole system. Focal infections, focal infections are a little unusual. Maybe this is the best. Periodontal disease. Typically, periodontal disease is something that strikes people as they get older. It's a disease sort of where the teeth are embedded in the gums. You may know somebody in your family, an older relative who had periodontal surgery, and effectively they have a lot of work has to be done because this is exactly what happens. It can be carried to another area. And I mean, this is a big problem, particularly if folks get older. You're starting to carry infection into the cardiovascular. If they have any kind of valvular damage, it's going to cause significant problems. From experience, that's something my mom had to have done. And my mom was, the word fastidious defines her mouth care. She was so careful. She said, I want to keep all my teeth until the day I die. And she did. It's just amazing. So she was like that, but the periodontal disease, I can recall having to have 2 or 3 of these rather extensive periodontal surgeries, right? To almost strip away areas where the teeth are embedded to let it heal and reform again because of the potential. Very unpleasant, very painful, a big deal at that point. And now we do see a lot of mixed infections, and by habit, some of these are mixed, means there's multiple organisms causing the problem. They could be a mixture of aerobes and anaerobes. They could be a mixture of gram positives and gram negatives. From experience, you see a lot of them in diabetics because of the compromised nature of the host. And so human bite infections, which we will talk about in class, are classic for that because the human mouth is a freaking cesspool of bad guys. wounds, and depending on how dirty the wound is, and when I say dirty, this is the kind of thing where someone has an accident out in the field, uh, farming, maybe taking a fall of a ladder from a height into an area on the side of the house you're working on, and all of a sudden you cut yourself, and there's all sorts of soil that's in, and that's really where gangrene is the same type of thing that comes in. Those wounds get a lot of debris and fragmentation and things in that. Again, taking a fall outside, running around, and all of a sudden you're in the dirt and your bone is exposed. It's just a guarantee of big problems. I commented on this before. With a primary and secondary infection, the classic example, pardon me, for all of these, quick sip of coffee this morning. A primary example for all of these would be influenza, the flu. Flu generally gives you pretty significant bronchial area problems. We cough, chest pain, bringing up stuff. That's the primary infection. The big problem is it paves the way for secondary bacterial infections. I talked about it in class recently. Secondary bacterial pneumonia. So, very often, viral infections pave the way for bacterial infections. Viral will be primary, bacteria will be secondary. When we see something, oh, this person has diabetes and they got an infection secondary to their diabetes, that's not a secondary infection. The infection is primary, the underlying cause is why we call it secondary too. It's all about the wording. That's what test taking is about, understanding the wording. So the second infection from a different microbe, which complicates the primary infection. And yeah, the primary infection is lowering defenses. So we see this with fungal, viral, parasitic infections. Typically, bacterial infections, because of their toxicities, cause more damage. And so we're always on the lookout for those. That's why in certain cases we do use antibiotics in a viral infection. Oh, somebody comes in with a viral pneumonia and they're at risk, we're going to give them antibiotics in a prophylactic sense because there's a significant problem with that. So, acute, we looked at this already. Acute infection comes on fast, lasts for X amount of time, goes away relatively fast. Chronic infection persists over a long period of time. Pretty standard stuff. People use these terms inappropriately. Signs and symptoms. Oh, Mrs. Jones, what are the symptoms of your disease? Do you have any bleeding? Is there any drainage coming out of that, etc.? That's not a symptom. A symptom is something that is subjective. It's the patient describing to you, it hurts. I'm nauseous. I feel woozy. My stomach feels like it's just getting clobbered all the time. I have this constant urge to go to the bathroom. Those are symptoms. Subjective means they're telling you something. You're recording that. A sign is objective, means it's observable and measurable at the very least. So where pain comes in, this hurts. Oh, that's a factor. On a scale of 1 to 10, who cares? You just get an idea. Is it really hurting you a lot, etc.? The difference is, okay, where does this hurt? Well, I'm going to examine it. I'm going to touch it. And all of a sudden you push on something and you push around. All of a sudden you hit one spot and they jump. That's called pain on palpation. That is a sign rather than subjective. If you see someone vomiting, that's a sign. Nauseous is something that they feel. They're not the same. So if we say, what are the signs and symptoms? So generally when you learn about how to record when you're doing a history or you're evaluating a patient, the symptoms are their complaints. What is their chief complaint? What are the other things that are associated with it? Yeah, I do this. Yes, when I do this, when I bend over, I feel dizzy, whatever. Okay. And then the examination. All right, I want you to close your eyes. I want you to do this. Now we can demonstrate that they're unstable. That's not, and then we can measure that. That's a sign. Signs and symptoms, not the same. If you just remember that signs are observable and or measurable, that's significant. That will tell you what a sign is and what a symptom is, or the distinction. A syndrome is a compilation of all these signs and symptoms. Diabetes is a disease, but really is more better stated as a syndrome. It's a syndrome that is associated with irregularities associated with high hyperglycemia, high blood sugar. That includes some of the following: Okay, so that is a syndrome. I know we categorize it as disease, but technically it is a syndrome. There's a compilation of signs because it presents differently. We have type 1, we have type 2, we have ones that are controlled, ones that are, etc. All of those types of things are there. Classic. The four big players. Now, if you had immunology, you probably learned about it. We call these the cardinal signs: fever, pain, soreness, swelling, etc. So, calor for fever, pain, dolor. Excuse me. Okay. Whoever did the PowerPoint again doesn't know what they're doing. I'm sorry. There are four cardinal signs of inflammation. Allow me to elucidate. Rubor, redness; dolor, pain; tumor, swelling; calor, heat. Redness and heat come first because inevitably those chemicals that are released when something becomes inflamed dilate blood vessels and tiny capillaries, and there's an increase in flow to the area. Okay. And there's an increase. So what happens when we begin to see that, we see a lot of blood going in there. It gets red and it gets warm. Those are the things you look for first, particularly in a post-operative infection. Put your hand on it, use the back of the hand, you have rubor and calor. Okay, then the swelling, it's called tumor, and then the pain, which is called dolor. So red and hot first, typically in that order, swollen next, painful next. Cardinal signs of inflammation. I don't quite get that where it is. So if they're describing fever for heat, I mean pain I can accept. I mean, pain and soreness are I get different sides. They're just difference between what, a nickel and a quarter. I don't know. Yeah, happy I did. That's why I use a different PowerPoint tradition. It's the first time I've used this one. Yes. So edema, accumulation of fluid, that's something that's very significant. You should have heard about that already when you looked at the circulatory system. Is that a sign of inflammation? No. Again, that's just something that may be accompanied of it, an increase in the amount of fluid. I wouldn't ask you the distinction in abscess, and because we talk about it in skin, and we'll talk about granulomas later. So they'll be in a different area. But effectively, walled off collections of either cells, tissue, fluid would be probably where these are. But this is not something I was going to ask you at this point. That's more of something that we'll deal with on the final. And swollen lymph node, swollen glands. Mom used to feel them when you were sick. It's called lymphadenitis. Okay. Increase when you see penia, it means too little. When you see cytosis, it means too many. Okay. And another one, if you see leukemia, basically associated for a vast number. Leuco for white. Okay. So when we see someone with a leukocytosis, then we look at it. Is it neutrophils, which point to a bacterial infection? Is it lymphocytes that point to a viral infection? Is it eosinophils? All of these are terms you should have had already in AP2. And if you didn't, ask me, let me know. I'll be glad to give you a quick explanation of it. Pardon me again, my voice is not so good this morning. So we look for those. Eosinophils would be a parasitic infection. Septicemia is where not only do we understand when you have a bacteremia, we transiently get that frequently when we eat. We transiently get it when we brush your teeth. We always get it when we go to get your teeth cleaned and scaled. Okay, it's nothing unusual. That by itself does not mean this is a terrible thing. It is, depending on the bacteria, certainly. Viremias, those are bad. Those viruses should not be going in your bloodstream. Again, maybe there's something transient and they disappear and it's very low numbers. Then maybe the count might be influential. Septicemia implies not only do we have maybe one of these bacteria or virus or some type of microorganism, and it's not just about the numbers, it's about the severity. Is it producing toxins? Is it producing a profound response by your immune system? When someone is septic, they are going to die. if you don't do something about it. That is an emergency situation. If they have septicemia, they're going to end up most likely in ICU, at least for a night or two. Usually, you're going to have to open them up and find out why they're septic and somehow remove it or treat it. That would be the burst appendix. That would be a tumor that has perforated something. That would be an infection that has gone out of control and caused significant problems. You're going to have to address that right now. So when we call them asymptomatic or subclinical infections, it's just that. Either somebody has one and it doesn't affect them, or they're developing one and it hasn't become apparent yet. Okay. But the microbes are there, and there's not only, it's not that I don't want to have a doctor look at this, they don't even know that they're sick. This brings us into the realm of what are called asymptomatic carriers. Typhoid Mary had active salmonella infection that did not affect her. So when she went to the bathroom, and she was a cook, famously in New York City at the turn of the last century, a lady from Ireland who was a wonderful cook, coveted every wealthy family in New York, the biggest families, the Vanderbilts and stuff like that, people who were extraordinarily had a ton of money, were wanted her to do her food preparation. All of a sudden, people are getting sick and dying. And she wasn't sick at all, so they never bothered to look at her. Well, and finally, and this was the early days of like investigations for epidemiology. She was the piece that connected everybody, and she was protested. I'm not sick, never sick a day in my life. But she was shedding this. It was on her hands. People didn't do scrupulous hand care. In fact, they weren't wearing gloves when they were doing food preparations back in the old days. Okay. So they really it was totally different the way things were there. But so she was the asymptomatic carrier, and salmonella typhoid is a salmonella infection, just to clarify that. So that is all part of why we're so concerned about that. And there's asymptomatic carriers for MRSA. There's asymptomatic carriers for a number of diseases. I mean, if you look them up, you'll be able to find them. And so this is where portals of exit come in, how they exit. Okay. Secretion, maybe on your skin, excretion, very, very common. Discharge, pus, mucus, that type of slough tissue. Those would be, you could easily have staphylococcus and lots of skin cells that are shed constantly that are there. And so all of these increase the likelihood that they're going to infect somebody else. Typically, and I said this before, the exit is usually the same way as entry, but it's not necessarily always like that. It could be, but it's not necessarily. For instance, uh, even though it would be rare, someone who never was immunized for chicken pox, if they ran into a person who had shingles, those areas where the shingles are present are going to potentially be shedding some chickenpox viruses. And if that person had never had the chickenpox or never been immunized, they would get chickenpox from that. And that's from skin contact as opposed to respiratory sort, just to give you an idea. I'm not going to ask you about that exception, but to point out it's pretty darn rare for these things to happen. And so these are the way they are: coughing and sneezing. This is the way somebody who have potentially something that's in their bloodstream or in their tissues, like they had developed yellow fever and there were other insects around, they could pass it just the way. And this is kind of the way things like malaria are spread when you're thinking about sub-Saharan Africa and things like that, where mosquito bites. I mean, mosquitoes are a big player, but obviously potential blood splatters, needle sharing a needle in drug addicts, feces, that's typhoid Mary, urine, same deal, skin cells, open sores, all of that. So this is really when we're trying to figure out what's doing the damage. We look at this. That involved with the microbe causes disease in a host. We got to look at the portal of entry, see that it attaches, whether it's fimbriae capsules, proteins, viral spikes, avoids the host defenses, causes damage by whatever type of means, and then it exits. I mean, and what's interesting about these are, again, understanding the process it goes through gives us ideas on how to either avoid it or treat it. So whether we make sure our skin is intact, we try to not come in contact. Again, think of hand washing all the time, having an intact immune system. Once the damage occurs, being aware of the problem and understanding how it would exit. And that's when you get into these types of things where people don't know. Okay. And and I think we've been overly sensitized, of the appropriate word, in the COVID era, because people, oh my gosh, it's crazy. Somebody would cough and everybody would run. It's like, oh, goodness. Please, killing me. You're familiar already with latency. Okay. Certain infections that are really part of chronic infectious diseases, some more severe than others. I mean, obviously. The herpetic infections are classic for that. Herpes simplex, 1 and 2, oral and genital herpes, herpes zoster, which is the presentation after you have chickenpox or shingles, hepatitis B, and hepatitis C for that matter, Epstein-Barr for mononucleosis. Effectively, that is in there, and AIDS would be a classic example of all of those, but maybe it really doesn't, because if it's untreated, it's not really latent. It's just gradually starting to do damage. I think that's a bad example. Syphilis goes through, and we'll examine the latent period that's there. Uh, Again, your immune system can keep things like typhoid intact, and that's the example of having really just a remark, for whatever reason, an immune system that for whatever reason didn't allow her to get it, but allowed everybody else, because that was really what they were getting, typhoid fever. And tuberculosis, we'll look at. Malaria, we'll look at as well. These are all different things that go through some kind of latency period. And latency typically means, for these, it's just something that is part of the virus and the way it impacts us. Here, this is a little bit more with immune system. Syphilis is an odd, going through certain stages, because we'll look at syphilis when we look at Lyme disease. And when you and I would call them complications. In doctor, we say sequelae. Because when you're talking about a patient, you don't want to say, what did you have? You don't want to say, you have any complications, get them buzzing with something bad. Sequelae means the event afterwards. We were always taught that. So things like that. And death would be a significant sequelae, but potentially hearing impact, strep throat, rheumatic heart disease, or rheumatic fever, Lyme disease. I'll tell you about that with different kinds of arthritis, polio, permanent degrees of paralysis. Yeah. So that's the sequelae, the aftermath. Sequelae literally means events that follow. And we looked a little bit at this when we looked at viruses, the incubation period from your contact to when it starts to appear symptoms, multiplying, not create symptoms, varies, host, is it how virulent it is, how far away from where it has to go, hours to years. And see, and this is probably a fairly accurate range. A cold might be a couple of days. Something else might be much considerably longer. Interestingly, again, something like HIV has a pretty long time of incubation before you really notice it. And that's the problem, because if you have multiple contacts, potentially you can't point and trace back to try to control it. The prodrome, that's the phase when I feel that tickle on my throat. I'm getting sick. You hate that. Okay. Vague feelings, malaise, generally doesn't feel good, aches and pains, upset stomach. Just when I'm tired. If your immune system handles it, it goes away. It doesn't get to the acute phase. That's your immune system doing its job. Okay. Oh, I had that 24-hour bug. I feel better. No, that was your immune system solving it in the prodrome phase. Versus the acute phase, for whatever reason, it's just more severe, more virulent. Maybe for whatever reason, your immune system's limited. It's just a bunch of stuff going on. You haven't been eating properly. You were sick, last week, and you haven't really recovered. Blah, 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 blah. Multiplies at high levels, highly virulent then, well established then, signs and symptoms. And depending on it, they all have their own signature. How long it stays with you, how short or how long the incubation, how short or how long the convalescence. Okay. And it depends. And there's so many variations. And that's the point made with the antibiotics. The fact that you're over that hump and you're starting to convalesce doesn't mean you should stop taking the antibiotics. I mean, that's part of it. It's our job to understand the life cycle and explain it to people if you're in a clinical situation. All you can do is tell them you can't control, can't watch them home and make sure they take their pills, have them come in and do that. It's not feasible. It's a little different in when you deal with addictive diseases and people in methadone clinics, which we had a lot of experience with, but this is totally different. Okay. And continuation phase is relatively rare, being able to linger and all that. And I don't really have any examples that are apropos, but this shows you some of those periods that are there. Okay. I mean, this is a little more the big take home points from these. The reservoir is where you usually find the pathogen, the bad guy. Interesting, the ones that we have the best chance of controlling are in animals or in ourselves. We can quarantine ourselves or quarantine those who have it. We have a variety of animal and pest control. We can spray for mosquitoes, all that good stuff. This is the big problem: soil and water, particularly water supply. Okay. Plants maybe we can avoid. Okay. Soil, we could take step for cleanliness, but we can't get rid of them in the soil. Water is particularly difficult. That's why, I mean, when you think of those doomsday scenarios of being either an airborne agent that's been released that we have no control of stopping, it's in the air, or in the water supply. Oh, scary. So, transmitted, the individual object from which an infection is acquired. Syphilis, strictly human. It's only in humans and it's transmitted human to human. We'll get into that disease, but sexually transmitted diseases, it's poster child, hepatitis A. The reservoir is human, but the transmitter is contaminated food. That we call that indirect spread. If I have hepatitis A and I touch you on your skin, you're not going to get hepatitis A. Assuming you wash yourself and all those kinds of things. We shake hands. But if somehow food gets in between and we consume it, because remember, we get it by ingestion. We talked about that earlier when we looked at viruses. So that is an indirect spread. A worker with it who has the disease in the food chain somewhere, like they were at Chi-Chi's, handling that stuff, and then gets sick and then handles the food. You consume the food. The food is the fomite, the object that's in between it. So it's indirect spread, but it's by ingestion or from food and water consumption. And so these are all the things. So when we have these living reservoirs, whether they're all these are a little bit easier to control. Non-living, not so easy. TB can survive for long periods of time in the air, particularly stays airborne. That's why it's such a problem, particularly in a closed environment. And so all of these, so there's a lot of possibilities. Typically, when you and I cough and sneeze, we call it droplets. Okay, so assume it's not tuberculosis. But you just got a cold, you have the start of a flu presentation, even you have COVID. Let's start with something everybody's so scared of. The reality, which you shouldn't be. The reality is they cough or sneeze. It's suspended in the air for a minute or two, then it drops. That's why they call them droplets. Gravity takes them to the ground. Things like tuberculosis, things like hantavirus, that one that comes from rodent droppings, stays suspended in the air. That's called airborne. You, People use terminology and, oh, that's spread in the air. Yeah, I know. Oh, that's an airborne virus or an airborne bacteria. I'll buy that. But in a technical sense, it is not the same. There's droplet transmission because it drops, it stays suspended for a limited period of time. Person next to you coughs or sneezes, it's suspended in the air. You might get something. But eventually it's going to drop. Now it's on the desk. It's on the floor. Maybe you walk in and you kick it back up and you temporarily suspend it. So you have to understand sort of the logistics of the way this happens. So, I mean, human to human is very common. And we call those a carrier who inconspicuously shelters a pathogen, spreads it to others without any notice. Okay. So it's an obvious source. You can see it. But asymptomatic carriers are a problem. So someone who has gonorrhea, they would normally be aware of it. I think that's a bad example. I rarely have seen gonorrhea. That's one of the big problems. It's very symptomatic. That's why it's treated so much. But herpes, HPV, oh, big problems. Incubating carriers, somebody with mono. So again, they may feel that they're getting sick, but you can still get it. Convalescent carriers, so it's hepatitis A, even though they're getting better. Chronic carriers, that's again, we get the typhoid Mary, and tuberculosis is a minefield because a lot of people have it latently. Okay, and passive carriers, this is where you guys come in, many of you. Healthcare associate, medical and dental personnel who must constantly handle patient materials, which are contaminated, blood, pathogens. You want to do this? And most of the time, when it's animals, it's typically we're thinking arthropods, fleas, ticks, mosquitoes. Okay, and obviously larger mammals with rabies, birds, potentially something called psittacosis, which I don't go into in this class. Lizards definitely have salmonella. And I mean, this is the type of thing you have to be aware of if this is an interest of yours. Okay, if you're working out of the field with birds, be aware of it. I mean, if we have a lot of students who are in environmental science and ecology, and they're doing studies and they're going out. Dr. Hannah here is who is our zoologist, our animal person. She's been studying salamanders and has which are certainly more in the amphibian category, but she's out there in the field all the time. That's one of the areas where she studies. There's a nature area on the other side of the river in Sewickley, whose name escapes me, but she's associated with them. And this is interesting because they talk a little bit about COVID-19. It's zoonotic origin in the sense that it was mostly from species, but what happens, and we will look at that genetic reassortment, particularly when we look at influenza, because it's really the same thing, because it's something this can affect multiple species, and just so happens we had a confluence of animal components that got involved with the human component. So, but here's zoonotic infections that are transmitted from animals to human routinely. And that's a good teaching point. If I was asking about an exceptional change or anybody, they should note that. Okay, this is the usual way that it's transmitted most commonly. Okay, that it's a little bit different. Okay, when we think of those things, it's like, remember I told you the anecdote about rabies. It could be human to human. Yeah, if somebody bit you with active rabies and it was in their saliva, they'd be at the end stage. That's what happened to somebody who we knew way back. This is a good 40 years ago. Who was a psych nurse. The flip side of that is that's not that usual, but it was necessary to mention it. So animals, but naturally transmissible. A lot of them. Influenza is one of those that has a lot of different hosts. Okay. Coronaviruses, a lot of different, as we call that, a wide range, complex life cycles. And so again, this is when we have close association in those areas, a la the alleged, open air market that was there in Wuhan, which is millions of people that are there. And as you can see, it's full 70% of all emerging diseases worldwide. Because of this, we're going into areas where we haven't been to before. We're encountering a lot more areas in the wild where people are seeking that out comparatively. Okay, and so and the trouble is, you're going to areas that now people are choosing to go into for a variety of reasons, and you're encountering new things. If you want to consider that disturbing the ecological balance, I would buy that. You can't do anything in one area that doesn't affect the planet. You can't start chopping down a bunch of trees and not have that affect the planet. You can't start building in an area that was in the wild and not affect the planet. It's just the way life is. So it's a nice laundry list that you can see. We'll talk about the ones that are relevant to us that are there. The big problems are these non-living reservoirs thriving in the soil, water, and air. all of these things. Most of these are not a problem to us, but there are some opportunities. But yeah, there are some regular pathogens. We're in regular contact with these is the big possibility. And this is the problem. We can't avoid this. You're going to breathe the air. You're going to use the water. The soil is going to come on the bottom of your shoes and work its way into the house. It just is. Can't help it. And so we get into the idea of this kind of thing. I think I'll stop it here and we'll get into the idea because it's in the concept of communicable and contagious and non-communicable that we're going to go into, and the different kinds of transmission are certainly important. And that's how really where we do. And then we end up, and I'm just scrolling through to show you, because we're getting to the field of these health associated infections, really important for us. And then Koch's postulates. And then finally, when we're done with this, we get the epidemiology. So you probably have one more big section to go through in regard to this. So I thank you for your attention. This will go out to all of you today. This is the 31st. April Fool's Day tomorrow, but thankfully it's our last day to be here, depending on when you listen to this. And I will be talking to you soon.